with the form. If you are interested in having, and I'm not sure of the logistics and all of that of this yet, but if you would like a posted recording of the class, like on the Canvas page, would that be helpful to you? Yes. Whoa. Okay. All right. Note it down. So how do you all get recordings now? Do you have like a group chat they posted on, and then you're like, oh, no?
John, listen to the recordings or no?
I don't
Sometimes.
care.
I record them and I never listen to them. I'm like, oh.
Okay, so do you get really good recordings on your phones?
Sometimes.
If I stand right here and say, oh well. So I'm just trying to think of the best way. If you do you get a good recording?
Oh yeah, I mean if you walk around and
I know, I can't. Really because I can't see the screen because I can't wear my glasses. Okay, so if you share it with me, can I post it on Canvas? Would that be helpful? Yes? It amazes me you guys want to listen to this over again. Oh my God. Okay. Fine. All right. So we'll see if we can do that. You can let me know if it's working, if it's not working, if the recording is not loud enough, and we need to get like a something special. We can look on that. So, but that doesn't mean that you cannot. So you're not coming to class, right? Just because you have the recording. Because there's still all of those super fun in-class activities, like maybe today, maybe there might be in-class activity today. Okay. So you're still going to have to come to class even if you have the recording. It's not a substitute for class. Okay. Next. So did you guys see my announcement on Canvas about assignments and grades and all of those things? Okay. So you may see a change in your grade. There was one question, it's my fault, sorry. I meant to edit the question and didn't. So if you have that question correct, you receive credit back for that. So you may see a change in your grade, but you might not. It was just one item. Then the other thing is for assignments that are turned in late, I did give a 75%. I talked with Dr. Lippy, and we decided 75% if you turned it in within 3 days. Okay. So if you have late outstanding stuff, please go ahead and submit that. Practice A, you still have to turn in practice A. You really want you to turn everything in on time. If you have like a disaster or something, send me an email. Okay. So when does practice B due? Not tomorrow. Do you see it on the calendar when it's due?
28 today.
There are some assignments that are the dates 2020 instead of 2021, or do we still do
In module 3? Or are they
showing up
module
under
2?
assignments?
The liver assignment?
Yeah, you can come over.
So liver, I think, is in still module because it's on the third exam. It's not open, so you can see it. Well, don't look at it. So anything in module 3, that's why it's still closed, is because I got to make sure that the dates are all correct on there. So any content that's on exam 3, I will be getting to that very soon, I promise, to get module 3 open for you.
That'll be exam 2.
What was I saying?
Next week?
Yeah, this week.
Oh, when is practice B due?
Although, yeah.
Okay, November 28th, so it's coming up. How about those targeted exams for respiratory and what's the other one? Electrolyte, maybe?
you don't see that much.
That's it. So those I try to have the targeted exams due before the test. Right, because the idea is that the content on the targeted exam is going to help you for the exam. So I'm giving you until like the night before the exam, until they're due. Yes? So is it just respiratory? Maybe it's just respiratory.
The question you have 58.
Okay, so electrolyte is in module 3 then. So don't, like I said, don't worry. We'll get those updated for you. Question? submit it? Yes. So you can submit your remediation for practice B.
Schedule for the exam. The schedule for the exam.
It says that.
So this is a respiratory?
Yeah. Tomorrow.
Tomorrow?
Oh, tomorrow all the respiratory.
That's a really great example. So she's asking, can I hurry up and make the column for your CME because you're putting numbers in there. That's great feedback to me because I'm like, well, you haven't even done it yet, so why do you need? Okay, but I get it. Okay, great, good to know. Yes, my committee. Any other housekeeping items? Yes, no? Okay. All right, well, we are going to get started here then with acute abdomen. Oh, whoa. Okay, so what are we going to be talking about today? We're going to be talking about the acute causes of abdominal pain. We're going to look at some assessment data for kind of these top common things for acute abdomen. We're going to look at lab and radiological studies for these things, and then we're going to talk about collaborative nursing care. What the heck do you do for patients that have acute abdomen? So, what is the difference between acute abdomen and all the abdominal things you talked about in adult 1? What's the difference? Besides like in adult 1 and adult 2. Sure, we're talking about acute pain, right? Rapid onset that's not getting better, right? It's not this chronic problem that you've had for a very long period of time and you've been taking medications and doing all of those things, right? This is something that is acute and it usually comes on very, very quickly and is very severe. We're talking about the patients that are presenting to the ED, okay? My daughter yesterday decided she didn't want to go to gymnastics, so she says I have stomachache. Not what we're talking about here, okay? And these patients that present to the ED usually require quite urgent or emergent interventions, and a lot of times these are surgical interventions. So just some fun facts about acute abdomen. It's a very, very common reason to see pain. Who's in the ED this semester? Please rotate it through there. Okay, lots. Have you seen patients that come in because they have pain in their abdomen? And it's a very like nondescript, right? It's kind of like a female, maybe an older female who says, I have chest pain. Like, I just don't feel good, right? They don't say, I have crushing chest pains right here. It's radiating to my left arm. They say, I just don't feel good. My stomach just hurts. I don't know. Everything just hurts. It does account for 5 to 10% of all ED visits. And most of the time patients are discharged from the ED and really they just have kind of this like weird abdominal pain, but most of those folks do get better within a couple of weeks. About 40% of these folks are admitted with abdominal pain, and really the patients that we're really concerned about are the older adults, right? They have a very increased mortality rate versus some of those younger patients. Okay, this is a really cool website. It has a 3D rendering of all your guts. And it just is kind of cool. And you can click on it and it zooms in and you can go in and out, up and around. When we get to the liver, is it next week? It's the next week. The liver's coming soon. And you can kind of zoom in and out. Am I making you motion sick? So it's pretty cool. In your spare time when you're like, what should I do on Friday night? Okay, well you can. Who's going to Worst Fest? Ooh,
Oh,
okay.
thanks for the
Last
reminder,
night,
actually.
right? I mean, not that I know.
Thanks for the reminder.
All right. So a great website, like I said, for you to kind of take a look at those and see if there's, give you a really good idea. Because what is important about the acute abdomen is understanding where all of your organs are located. If you understand where they're located and where the pain is, you can figure out what organ we're talking about and how to treat it. So understanding pain is really important, and understanding that it's really the thoracic lumbar down to the sacral lumbar, and again, where that pain is located. So this is a really great chart from the Lewis textbook. And it has some causes and then signs and symptoms. And you'll notice that a lot of the signs and symptoms are the same, right? So there's a lot of overlapping. Okay. So, and we're looking at referred pain. Again, when we're thinking about, for example, that patient with chest pain and they said it's radiating to my left arm, that's a very classic description of having an MI. For acute abdomen, there are some places that they do have referred pain that is very, very specific for that organ, like the liver. Okay, you can see it. Where the liver and the gallbladder are up there, again, showing you exactly where that patient is having the pain. So understanding what part of the abdomen we're talking about, I think I've said this like 4 times now, is crucial. Okay, and you can use your very good nursing assessment skills to describe which area of the abdomen you're talking about. Most of the time, for our purposes, we're going to be talking about right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Okay. So there are those patients that come into the ED that really have generalized abdominal pain, right? So when you ask your nursing questions about their pain, what do they say? It just like hurts everywhere, like everything hurts. Okay, so we want to really make sure for these patients that we're thinking about those high alerts. Again, maybe we're on the acute abdomen. And one of the highest concerns we're thinking about is perforation. What does perforation mean? Poke a hole, right? So we poked a hole in it, and now there is free air in the abdomen, or it bleeding into the abdomen. Okay, so we're going to be on very high alert, those patients that say they have generalized pain in kind of their whole abdomen. And we're thinking about AAA, right? One of the things on very high alert. We're also thinking about pancreatitis and about bowel dissection. So again, the whole abdomen is hurting, and we're going to try to narrow it down. Okay, if they have central or periumbilical abdominal pain, just kind of right by the belly button, you might think of things like appendicitis that's early. We're going to talk about some kind of more signs and symptoms of appendicitis in a minute. You might think about acute gastritis, acute pancreatitis, or a ruptured AAA. Again, what organs are right there? Right there in the middle. There's kind of a lot of them, right? So if you look, I don't know, my printer's, it's super late. But if you look right here, look, you've got the top of the stomach. You've got a little bit of your intestines. Of course, you have your aorta, your abdominal aorta, that's kind of behind that. So understanding where the structures are is very helpful for diagnosing. Epigastric pain, so esophagitis, acute pancreatitis, and that AAA. Gosh darn it, AAA is like everywhere because it's like the whole abdomen, right? What's that photo right there? I know you guys aren't experts at reading radiographs, but
Aortic aneurysm.
aortic aneurysm, right? See that bulge? Okay, and then when you come down here to the bottom, this is going to the right and left leg. Okay, so you can see this huge bulge right there. Okay, now we're on to the right upper quadrant. So again, what organs are in that right upper quadrant? Your liver, your gallbladder, your pancreas, right? So why is pneumonia on there? We're talking about the acute abdomen. Why is pneumonia on there? The lower right lobe. You've got that right lower lobe. Okay, so sometimes patients will complain. We're going to talk about all things pneumonia tomorrow. I know you're thrilled to be talking about respiratory. I mean, today, acute abdomen is the abdomen is my favorite organ. Tomorrow, it's going to be the lungs. The lungs are so good. Okay. But yes, those patients that have pneumonia or maybe a PE, a pulmonary embolus, will complain of that right upper quadrant pain. Okay, so what do we have here? Probably, so this is an ultrasound. On the left side of the screen is an ultrasound. And then on the right side of the screen, we have a KUV, or a kidney ureter, bladder, ureter, kidney KUV. That's what we have the acronym. So it's basically an X-ray of the stomach, or of the lower abdomen. And those are some kidney stones. Look at those nice little balls right there. Ouch. What else do you see in that photo? Air. How do you know it's air? Because it's black. Is it supposed to be black? No, it's not supposed to be black. So, very concerning. All right. Gallstones as well. This is a ultrasound versus like a KZ. Both gallstones. So left upper quadrant, again, we might have a little bit of that pneumonia, kind of some of that referred pain. What's the other thing that patients do when they have pneumonia? They're coughing. What are they coughing? Sputum, lots of mucus. What happens when you cough a whole bunch? Right? Those intercostal muscles are what squeeze your ribs together, and those intercostal muscles can get very sore. You can actually, in the elderly, I have seen patients that have coughed so hard they've actually cracked their rib. So you might also get some, depending on what rib it is, you might get some kind of upper quadrant either on the right or the left pain from the really challenging coughing. Again, pancreatitis, you might consider a splenic rupture, and acute perinephritis. All right, down to the left lower quadrant, acute appendicitis, which is probably the most common acute abdomen, both for pediatric patients and adult patients. Coming in with acute abdomen is from appendicitis. You might see some diverticulitis signs and symptoms in that right lower quadrant for pain, pelvic inflammatory disease. Oh, these words are all like impossible to say when you're standing up here. UC, and ectopic pregnancy and Crohn's disease. Again, you're looking at what structures are there, and you've got your, what are those things? Your bowels. Your bowels are right there. All right, so some really good photos for you. Again, you have heard of ectopic pregnancy, which is a pregnancy in the fallopian tube. You can see like a real life picture on the top. And then the appendix and the left lower picture is a patient that has UC, ulcerative colitis. Okay, so ectopic pregnancy is going to be an absolute emergency. It accounts for about 20 in 1,000 pregnancies in the US. It does account for almost 10% of all pregnancy-related deaths, and it is the leading cause of mortality in the first trimester. And it does have a increased risk of reoccurrence if you do have one ectopic pregnancy. So we do, if someone comes in to the ED with abdominal pain and if they're female from age 10 to 60, we will do a pregnancy test to rule that out first because it is very easy to do. And yes, I did say 10. Left lower quadrant pain, we're thinking about constipation, diverticulitis, IBS, which just happen to be my initials. Isn't that super awesome? I have to throw that in there. You might also consider pelvic inflammatory disease, as well, again, as an ectopic pregnancy. Okay, what do we have here? So you just look at this and just kind of cringe a little bit, right? So have you guys, when you have a diagnosis on your patient, do you pull up their chest x-ray or their KUVs in clinical and take a look at them? No, you don't have, you're not experts, right, in reading them because you'd have to go through a radiology class in order to do that. But you kind of look at it and you're like, okay, so that doesn't look good. That like makes the hair on my neck stand up just a little bit. So if you look at this photo, your hair should stand up. What is that? We just talked about It's actually stool. Make a mistake.
Stool is
It's
escaping.
a patient that is very constipated, and you have buildup. So, what kinds of things would this patient be complaining about?
Bowel obstruction. Okay.
Yeah, so that's one of the reasons why we ask, when was your last bowel movement? Okay? And what do you think you're going to be doing for this patient?
How you going?
A bowel program, right? Okay. And so sometimes when you're taking care of a patient, maybe that had an x-ray like this, and this x-ray was maybe yesterday or maybe last evening, it's going to be you that's on, right? During all of this. So what can you, we're talking about practical tips here. What can you do if your patient is having lots and lots of stool and you're having a hard time? Do you guys have hard time? Do you have like something that really kind of, you're just like, hard for you? For me, it's mucus. I have a really hard time with mucus. Also vomiting, just the sound of vomiting. So what are some practical tips when you're caring for the patient who was constipated, but they got milk of mag, and they got Dopalax, and they got some Senna, and they got all the things. And now they have diarrhea that's dripping off the end of it. So what are you going to do for you, for the nurse, who's taking care of that patient?
Give it before you leave.
No? Kill them. Just give them to another nurse.
So, of course, since we're all wearing masks now, that would be great, right, to wear a mask. You can put something inside your mask, just right in here, to help with the smell. But really, I want you to think about, we're caring for the whole patient, right? And even though this might not be our favorite thing, it's really our honor to care for this patient in their most vulnerable state. And so you really want to do your best to care for them just like you would for anything else, right? Okay. Mouthwash, you can put mouthwash inside your mask. It actually works really well. I think this air spray stuff, I don't know, it just makes the floor really slippery. So I like something that's like closer. Good chapstick as well. Okay, suprapubic pain. You might think about this patient with urinary retention. Would urinary retention be pre-renal, intrarenal, post-renal? Post-renal, you got it. Okay, and cystitis? Okay, and a UTI. Again, that ectopic pregnancy might go in several different quadrants. Diverticulitis and then PID also in the suprapubic area as well. So groin pain, actually the first differential diagnosis that we're going to think about for groin pain is actually muscle strain. And then we would think about UTI because you've got your kidneys right there. You might think about some renal stones, pyelonephritis, and an incarcerated hernia. Okay, some good pictures of some hernias right here. I like to play the grocery store assessment game. That means that when you go into the grocery store, you're like, ooh, I see on that shirt, there's like a big bulge in your shirt. I think you have a hernia. Or, oh, you're kind of like ashen and gray. I wonder if you have liver failure. Like those kinds of things, my grocery store assessment. Have you guys seen bulges under the shirt? Maybe see a patient that has one in the hospital. What do they feel like? A hernia. What is a hernia anyway? Yeah, it's a bulge, that the intestines actually peek through the muscle in the abdomen. What do they feel like? They're real squishy. Should you like squish it in and like push it back in? No, don't do that. But you can see there's lots of different places based on the intestine that is poking out, and they're labeled as such. You have epigastric, inguinal, femoral, umbilical, all of the hernias there. What's that top picture? What organ is that? Barely recognizable. Kidney, right? We've got a few renal stones for this patient, and unfortunately the kidneys are out of the body for a reason on this patient. Okay, history is where you're going to get all of your information, right? We use the acronym OLD CARTS. So we're talking about onset. So what question would you ask for onset? When did it start? Okay, so we're thinking about the acute abdomen. So what do you think are going to be your responses? 10 minutes. I drove really fast to the hospital here. So within the last 24 hours, right? Maybe 48 hours. Okay, where is it? We just spent 10 slides talking about how important location is, and it depends on what organs are there. So duration, what are you going to ask about duration? Yeah, how long does it last for? What makes it better? We're getting to relieving factors, but what makes it better? What makes it worse? When you mow the lawn, is it worse? When you bring your knees to your chest? When I put my hand over that quadrant and push down, does that make it worse? What does it feel like? Is it burning? Is it ripping? Tingling? Describing what their pain, and what will folks say a lot of times about the character of their pain? Well, it just hurts. You're like, okay, thank you so much. Okay. Aggregating factors, again, what makes it better, alleviating, or what makes it worse, and then relieving factors, what makes it better. And then we're going to talk about treatment. We're not talking about our treatment. We're talking about what have you done for this pain to help make it better or help make it worse. And then symptoms. Do you have any other signs and symptoms in your assessment findings? Are they nausea, vomiting? Do they have diarrhea? Do they have fever? Do they have pain that's radiating to somewhere else? Do they have that really mucousy cough? And you're thinking, okay, maybe not abdomen, maybe respiratory. Okay, OLD CARTS. Okay, so I talked about doorway or my grocery store assessment, right? I'm looking at you from way over here, and I'm thinking, are they sick or are they not sick? So my daughter who was complaining, I got totally worked. Okay, so she says, I don't feel good. I'm like, yeah. Okay, fine. Eat a snack. Do you need to go to the bathroom? Let's go. She did not look sick to me. And then the alligator tears started, and I was like, oh, fine, you're sick. Okay. But do they look sick? Do they not look sick? Okay, are they walking and moving easily, or are they guarding and, very rigid when they're moving? When they're in the bed, are they rolling over easily? Are they able to help turn, or they really can't do any of that? Is there obvious pain or overt pain? So we're going to talk about some assessment skills, and when you ask them to do this, if they're like, oh, it kind of hurts, or is it like, oh my gosh, that really hurts? Okay, and of course we are going to be taking vital signs often, and that's one of the very first things that we do is take some vital signs. Okay, so before the abdomen, and this goes with almost all organs of the body, the first thing we're going to do is look at it, right? Our tendency is sometimes to touch first or listen, but the very first thing we want to do is look first. We're looking, do they have any scars, any bruising, any distinction? So after we look at it, then we're going to listen before we start pressing on it, okay? And should you start on maybe it's on their right upper quadrant, where do you start? Okay, so you don't want to start with the area that's hurting, right? You want to move and look at all of the other places first before you go there. Do they have hyperactive bowel sounds, hypoactive bowel sounds? When you are listening to bowel sounds, how long are you? 5 minutes! 5 minutes! Oh my gosh, that's the longest assessment ever, right? Have you all tried to listen to bowel sounds for 5 minutes? I think I would quit. I don't think I could do it for 5 minutes. That's forever. So, but if you are going to mark on your assessment that they're absent, you do have to listen for a full 5 minutes. I think I'd give up after 45 seconds. And again, when you're laying in your bed at night and you have your stethoscope and you're tired of listening to your heart, you can listen to your abdomen to check on your own bowel sounds. Very, very calming. Okay, so after you look, listen, then you're going to feel. You start away, just like you did when you're listening, start away from the tender areas first. And then you want to ask the patient, does this really hurt, or is this tender? And you're going to watch them for guarding and rigidity, and Most of the time, the palpation is the most conclusive part of the exam, besides getting an actual picture. Okay, we're going to talk about Murphy's sign. What organ are we looking at for Murphy's sign? Which one? Where is it located? Look at that giant arrow right there. Not the appendix, because where's the appendix? Oh, the appendix is like way down the bottom. Okay, so we're looking up. Gallbladder. Okay. So we're going to place, you can all do this, place your hand firmly on your right upper proximal margin. Now take a really big deep breath. Nobody cried out in pain. Oh, hooray. Okay, so all of your gallbladders are all good to go. Okay, so if you have a positive Murphy sign, if the patient really, when they're taking that deep breath, they go, I can't do it, right? And the gallbladder kind of descends down to the hand, where you're pushing in on their right upper quadrant. Okay, so you all have a good Murphy sign. You can percuss on the abdomen. Do you all see percussing much during assessments? I do see percussing for the liver, over the liver, and Ms. Rice will be talking about that for sure. And the other place we do see percussing is in the lungs, but not usually on the lower abdomen because of the way that those organs are. You're not going to get any solid sound because the liver is the only kind of solid organ up there. Great question. Okay, so Murphy's sign, positive if they have pain, and it's negative if there's no pain. Okay, now, how about McBurney's point? That's the appendix. Okay, because we see right where it's located there. So you're going to have deep tenderness in that right lower quadrant. Okay, another way that you can check for appendicitis is a psoas sign. So you're going to have the patient kind of help them lay on their side. That's going to also give you some information, right, when you see them rolling over, how are they moving. And you're going to have them raise their lower knee up and kind of extend back their top leg. When they have the hip extension, because that organ is located right by the psoas muscle, when you kind of stretch it, they're going to cry out in pain. And then the obturator sign, again, rotating the right hip in a flexed position, kind of using that psoas muscle. Where is your psoas muscle? Like right here? Right? Right here? Right. I'm teaching a musculoskeletal content for the D&D program next week, so I'm on muscles. Okay. Okay, so some other common areas, again, you can look at this for some other acute ailments. This is a photo from your book. This is a great one talking about the inflammation, peritonitis, obstruction, or internal bleeding, and how this leads to a life-threatening effect. And then how this leads all the way to shock. So this is an excellent table. This is an excellent table from your book. Excellent. Okay. It's just, yeah. All right, life-threatening abdominal complaints. So you're thinking about cardiac, okay? You're thinking about, did their spleen rupture or is their spleen bleeding? Pancreatitis, which Ms. Rice is going to talk about, and then that AAA, whoop. And then again, the ruptured ectopic pregnancy we talked about a couple of times. So these are some urgent complaints. These might be complaints that have your patient admitted to the hospital, but they're not going like straight to surgery like right this instant. But they could become life-threatening if the patient waits too long or you're not able to diagnose it quickly. Things like appendicitis, cholecystitis, incarcerated bowel, rupture of ovary, perforated viscus, PID, and again those non-surgical descriptions like diverticulitis and inflammatory. Okay, so what do we do for an acute? Now we've decided, okay, great. They really do have a problem with their abdomen. What are we going to do? We're going to do a urine analysis. Did Dr. Richardson talk about specific gravity? Did he talk about calculating specific gravity? So it's usually 0.1 point. So specific gravity just means how
10,
heavy
10,
it
10,
is.
30.
And we compare how heavy it is to water. So water is, this is not going to be on the test. This is just good information for clinical application. Water has a specific gravity of 1, but your urine is a little bit heavier because it has sediment, electrolytes, it has stuff in it, so it's heavier. So a normal specific gravity is from 1.02 to 1.04. And if it's heavier than that, if it weighs more than that, you know that it's excreting things that it shouldn't normally excrete. Okay, whether that's protein, whether that's other electrolytes, whether that's a bacteremia infection. Okay, does that kind of make sense? We would do a pregnancy test. Like I said, we do a pregnancy test on any female that comes in with an abdominal complaint between the ages of 10 and 60. We're going to look at the liver function test to see if we have some liver problems. Ms. Rice is going to go into a lot more detail on all of those LFTs. We do a basic chemistry. We could do a basic metabolic panel or a complete metabolic panel. This is just a very general, going to give us lots of information about all body systems. What area of the chemistry would you really want to think about? If we're thinking about some abdominal something. What'd you say? H and H, so we could consider H and H if we have a low H and H. We could think about bleeding, right? And so what signs would we see in the abdomen if we have bleeding? Distension, right? Distension of the abdomen. Okay, I heard it over here. White blood cells. Okay, so we're really thinking about when we're looking at that CBC, yes, H and H, yes, electrolytes, but we're really thinking about WBCs. What is our magic number for WBCs? 10,000, right? So we're thinking about if it's over 10,000, we probably have some infectious process going on. What's unfortunate about getting a WBC is that's not going to say, hey, it's in the abdomen, okay? Because your WBCs are over 10,000. It's just saying in the body somewhere we have some infection. So, and if that's coupled with abdominal pain, that might give us some clues, but it's not very specific. All right, we're going to check on their glucose. It's going to tell us about their pancreas. We're going to look at ABGs. How are you all feeling about ABGs? Super? Great. I'm so happy to hear that because we're going to be talking about it some more tomorrow. Why would we want an ABG for this abdominal patient? What is it giving us information like yay or nay? Okay. What disease process did we kind of have on a couple of slides? Okay, aneurysm. Is the ABG going to tell us about aneurysm? No. What else is it going to tell us about? Well, kidneys. Maybe.
Respiration.
It could give us some metabolic information.
Respiration. Diaphragm.
Pneumonia. Oh, good. Okay. Have you guys been saying that for 10 minutes? Yeah. So we are going to, again, we're going to talk about all things pneumonia tomorrow, but an ABG is going to help us differentiate, is this an abdominal thing or is this a respiratory thing? PT and PTT is, again, going to give us some more information about the liver. It's going to tell us about their bleeding status and their ability to clot. We might look at their amylase, and we also might look at a CBC. Again, might just tell us some information with low sensitivity. Okay. The second most, well, I can't say that. Something that's very, very important for the patient with an acute abdomen is we need a picture, right? A picture says, I think it's like on my next slide, 1,000 words, right? So it's going to tell us exactly where the problem is. I was talking with Dr. Volker actually before coming down here, and he was saying, I think it's his sister that is a radiologist, and she's like, nobody does any assessments anymore. They just all get CTs or KVVs, like nobody's doing their assessments because the picture says so much. So you can do a plain film, which would be an X-ray or a KVV, and that's going to tell you about free air, maybe some fluid levels or any foreign bodies that might be in the abdomen. Ultrasound is also a really great tool to use. Ultrasound is something that's very quick that you can do at the bedside. It doesn't require any contrast like it would for a CT. Why do we care? Did I put it up there? Why do we care? Oh yeah, I did. So we care because if we're thinking about the abdomen, the kidneys are kind of a high alert right there in the abdomen, right? And so if we're worried about the kidneys and we need to do a CT, we might have to give this patient IV contrast, and that can really stress the kidneys. So an ultrasound is a really great way to kind of take a look-see without giving the patient any contrast or stressing some of those other organs. However, if we had to pick some sort of imaging, we'd probably pick a CT because a picture is worth 1,000 words. So these pictures on the left are all 3D images from a CT. So it gives you so much information, and again, a 3D rendering of the specific area that you're looking at. If there's an abscess, they can tell you approximately how many cc's are in that abscess. If it is stool, again, they can tell you approximately how many cc's. It just gives so much information. The problem with a CT, again, giving IV contrast, and it takes time. What else might you need to do for a patient when you put them in the CT scanner?
Move them.
You might need to sedate them, but what do you want your patient to be able to do to tell you? Does this hurt? Does that hurt? What about if I push here? What about if I push there? But now they're asleep, and you're like, okay, it's not helping me at all. So we might have to give them some IV medications in order to get the scan, but then we kind of lose that patient feedback about what is hurting and what is not. An ultrasound could give us, like I said, a very quick view. The picture on the right is a patient that has a AAA, and then if you look at the ultrasound, you can very quickly see, look, we better go straight to surgery. It's very quick. Okay, so nursing interventions. Really, we think about CBA, which is like in quotes, ABC first, right? Okay, we want to make sure that the patient is breathing, that they have heartbeat, that they're breathing first, and then we're going to look at that assessment. Again, we're going to look, listen, then feel, and those vowel sounds we might have to listen for a whole 5 minutes. We'd make sure that we had IV access in order to get our blood work, but also to give IV fluids. Okay, we always have to consider when we're giving fluids, okay, this patient is here for an acute abdomen, but what other comorbidities might they have that we would really not want to give fluid? Heart failure. So we really want to like beef this patient up because they have low blood pressure and they look really terrible, but they have heart failure, so we're going to have to be really considerate with how and what kinds of fluids we give. We already talked about analgesics, that those are really important to help alleviate pain. However, by giving those medications, we're taking away the patient's ability to kind of respond and like really pinpoint and tell us where their pain is. We might give some antiemetics. My favorite is like, oh my gosh, I feel like I'm going to throw up. It's like, here's this tiny little kidney bowl that we're going to give you that would just, have you ever thrown up in one of those? It splashes all over the place. And now they have a nice blue bag, right? But I think, was it in the very beginning of the semester, that seems like a year ago, the very beginning of adult 2 when you guys did simulation downstairs, and you had the runner that was throwing up, and you have a cute little kidney here. You need like a big bucket if you're going to throw up. These patients are almost always NPO. Usually they don't want to eat anyway because they're having abdominal pain, but if they are going to go straight to surgery, they do need to be NPO. So another assessment question would be, when is the last time you ate? And do they need an NG tube? Who's put in an NG tube? Couple? I'm an expert NG tube putter inner. Once you kind of like get just the angle is like just right. So these patients might need an NG tube for decompression. What color should it be coming out of their NG tube? If it's any other color than green, it's a problem. Like if it's brown, run for the hills. Okay, big problem. We need to be calling somebody immediately. Okay, so testing. So that's how we're going to zero in on what disease process they have going on. Whether it's testing with lab, whether it's testing with a CT, we're gonna just keep going and going and going. And it's usually, we tried this, and we say, okay, we're gonna do one more test. You try this and you're like, okay, I'm just kidding, we're gonna do one more test. Oh yeah, okay, just one more test. And during this whole time, while we are testing, we're gonna reassess, and check their vitals and make sure that there's no other process, that the patient isn't becoming septic, like right before our eyes. Reassessing. We're gonna think about their fluid resuscitation and electrolyte monitoring that we would get with our lab draws. And really controlling their pain and their symptom management is really key. And getting getting the consults in there, whether it's a surgeon or whether it's a GI OB, whether it's a cardiac or a vascular surgeon. And they would give you, of course, orders if they said, go ahead and start antibiotics, don't start antibiotics. We would get that information from our CDCs that we sent. And really emotional support for not only the patient, but their family as well. Sometimes these patients are in excruciating amounts of pain. Okay, that's fast and furious for acute abdomen. Question?
Not too bad.
Which chemistry is important? Yes, white blood cell count.
Dr. Leo, Dr. What?
CDC? What did I say? I didn't say, said something else.
Dr. Leo.
So you're going to look at white blood cell count. You're going to look at all of their electrolytes
Can I just stay together?
from those labs. Got it? Okay. So we do have an in-class activity. Did it pop up for you? Okay. So if you were listening at all, or you have the slides, you can use those on this quiz. It is 5 questions. You have 10 minutes. It will close.
Where is it?
I think I said at 2:05. 2:10, 2:05. So you can't like leave and come back. You're gonna have to go ahead and take a nap. Ready, set, go. So the only thing you can't use is your friend next to you. You can use all the resources. You can use Google. You can use the slides. Yep, go ahead and start.
All right, well, let's get going with burns then. Everybody do their reading?
Yes.
Yeah, no, maybe? I hope so.
Why am I gonna read?
I mean, some of this
And
is
then
going
tell
to
us
be a
half
repeat,
time.
right?
Hey,
Because
don't worry about
we're
that.
treating
Oh, okay.
conditions.
Thanks. I just read about it.
You know, might some of the treatment be the same as DKA? Hey, it just might be, right? All right, let's see how this is going to work today. I got my laser pointer there. It's always a challenge when you're in the Zoom room. All right, obviously we're going to start with objectives, right? We're going to look at thermal, chemical, and electrical burns, and then classifying further as whether they're superficial partial thickness, full partial thickness, or full thickness burn. So how deep down into the dermis, the skin layers, did the burn go? All right, we're going to look at the clinical manifestations, complications. What's going on? Oh, I don't have Siri, so I don't know who's going with Siri in the class. Was she answering my questions? Oh. I don't think she knows my voice, especially if you throw a mask and a microphone, right? Looks like some people were hungry. Give a couple minutes to get settled. If you missed the quiz, no. 2 quizzes in a row. God, did that suck? Yeah. I think quizzes are a way to get you guys motivated to attend though, right? Yeah. I've got one more lecture to go, but guess what? It's online next week. Aww. You know what? That's almost more work, because if I have to do a voiceover PowerPoint, yeah. I don't know. new to get used to. All right, is everybody settled? Yes. Ready to do some burns? All right, so we're talking about manifestations, complications, collaborative care, of course, because we're what? Interprofessional medical care team, right? We're going to look at the emergent and the acute phases of burn management. We're not going to look at rehab at all. We're going to look at fluid and electrolyte shifts during emergent and acute. And again, electrolyte shifts. Did we see anything like that last week or the week before? Yeah, we didn't see a lot of it. Because the body tries to react to things you do to it. All right, we're going to look at wound care techniques. Sometimes there's surgical options. And is anybody squeamish? No? Because there's some sort of graphic photographs. I mean, do you want me to warn you? We're coming up to one? Maybe. Because you don't get to pick at work at the hospital, right? You walk into a room, oh, there it is. All right, now we're going to look at nursing interventions in managing the burn patient, physiologic and psychosocial needs too, right? Because that's it's quite a traumatic experience psychologically being burned. All right. So burns are any injury to body tissue caused by heat, chemicals, electrical current, and radiation. Anybody ever see the Chernobyl special on HBO? I think it was last year or 2 years ago. That was amazing. It's just the power of radiation and the scope and the amount of people injured in such a short time over such a great area. So I highly recommend it, but we're really not going to talk about it much because I hope we're never going to see radiation burns here in San Antonio. But if you do get to see it. All right, so always remember, most burns are what?
Preventable.
Preventable, right? Safety in the home, safety at work. All right, so just some whiz-bang statistics. From fire or flame, 44% of all burns that come in are going to be from fire or flame. We see this all the time, right? You get the gas can, you're lighting your campfire, you're lighting your fireplace, your stove is malfunctioning. Oh, the heat's been out, the electricity's been out for 2 days, so, I'm trying to heat the house with the stove, with the electric ring, the gas ring. So, yeah, people doing things they're not supposed to be doing. Cigarettes unattended. Anybody ever see a patient smoking with their oxygen on in their house? I'm just saying, it happens. It happens. You're going to see stuff like that. And then not only from the flame, there's also the smoke. So breathing in smoke, breathing in hot gases causes further injury. Scalding is from steam or a hot liquid. 33% of the burn injuries are caused by that. Hot liquid or steam comes in contact with not just the skin, but also with mucous membranes, causes injury. Cooking and food preparation. Anybody ever have a diabetic patient who had a extremity injury or a whole body injury because they couldn't feel how hot the water was? It happens again. That's something you need to teach your patients, right? That's another way to check the water. Get an actual thermometer in there. They can't tell if the water's too hot. And who do you think has a lot of injuries from scalds? Children, right? We took on the stove. Again, the bathtub is too hot, they jump right in. A lot of scald injuries in children. Right, other sources, chemical burns, electrical burns, contact with hot surfaces. We've all taken that pan of cookies out of the oven, right? That got me. And that's 23%, so that's pretty low. And they're less likely to have them at home than scalds and flame burns. All right, so thermal, we can have some subtypes. Actual flames from flashes. You're lighting your fireplace, you're lighting your grill. You have a flash injury. Talk about scalds, contact with hot objects. So just some of the ways you can actually have a thermal injury. And again, it's going to depend on how hot was it. Was it just your big lighter, or was it the whole barbecue grill? And how long was the skin in contact with what was hot? It's just like, you can't let go. And there you go. And also it depends too on the medium. Like, has anybody ever seen burned plastic? Just kind of sticks, right? Yeah, so you got to look at, if there's scalding or what kind of other chemicals there are that's touching your skin or mucous membrane that's causing a burn. So that's kind of an interesting burn, right? What do you think it looks like? It's kind of red. Maybe a scald burn, right? All right, so we can also have burns in our respiratory system, inhalation burns from hot air, smoke, or other chemicals. Respiratory tract damage comes from that. And if you have respiratory burns, it's a major predictor of mortality. So do you think it's going to be higher or lower if you have respiratory burns? Right. Yeah, ABC. And, all burns, if they're severe, need to be treated quickly. All right, so there's another type of injury. It's not from actual fire or flame. It's called metabolic asphyxiation. Has anyone ever heard of carbon monoxide? What's the problem with carbon monoxide? Okay, has a high affinity to hemoglobin, right? So once it attaches, it doesn't let go. And what does that prevent? Right. Yeah. If you've got carbon monoxide attached to your hemoglobin, it's not going to release in the lungs and attach oxygen. So carbon monoxide poisoning displaces the oxygen, causes hypoxia because the carbon monoxide hemoglobin is all stuck together. And what are we going to end up with usually? So does that happen recently at all in San Antonio? When did it happen? This winter. What happened? Okay, so from cars, generators, right? So they were running their generator in the garage or running their car to keep warm. Some people brought the barbecue grill in from the patio, right? And so if you don't have sufficient oxygen to burn properly for those kind of sources, carbon monoxide builds up. And again, what's a way we could prevent that? Education, patient teaching, right? I know by the time they get to the hospital, it's kind of late for that, but just as a general public health issue. All right, so hypoxia leads to death when the carbon monoxide levels are 20% or higher. And if you do encounter a patient with that, what are you going to do? You're going to give them 100% oxygen. Try and displace that carbon monoxide. Sometimes it works, sometimes it doesn't. And the thing is, you can get a patient that comes in, it's like, they were feeling drowsy, they were a little confused at home, I just brought them in. Are there going to be any physical signs of burns? Probably not. It's where you have to play detective, right? I say that a lot. What happened? We were at home and we were trying to use the barbecue grill to heat the house up, and or the generator because the power was out. How many? Quick poll. How many days was everybody's power out this winter? And I see 4, 5. Anyone higher than 5? 5? Okay. Mine actually it was never off for more than 4 hours at a time, but it was over a 5-day period. But I didn't have water for a week. That was fun, right? And who would have thought it happens in San Antonio? All right, so let's look at some other upper airway problems. Actual thermal injury to mouth, oropharynx, and larynx. What's the larynx again? The voice box, right? And what's real important about that? What does it do? You can help keep things out that aren't supposed to be in there. All right, so we can have injury from hot air, from steam, and that would be a what?
Inhalation.
A scald.
Tissue.
Only 3 slides ago. right? Or from smoke inhalation. The respiratory tissues are very sensitive, they're very vascular, so you can have swelling very quickly. And what's that scar? Think back to foundations, you had to classify that wound, right? What's that scar? Right. Sometimes it looks like slough. Yeah, so that edema can compromise your airway. Lethal swelling from skull burns. So if we were to do a nursing, I'm going to mix it up. If we were to do a nursing diagnosis for a patient with a skull injury, what would that be? Impaired
Airway.
impaired airway. Okay. What about functionally? So yeah, it could be an airway obstruction, an effective airway. What about functionally? You guys should know this. What does air do? Air goes in and out. So if it's the airway, the air's not going in and out, what's impaired? There you go, ventilation. Thank you. All right. But if we have edema and there's fluid in the alveoli, then what is that? Impaired gas exchange. Yeah. They're going to get you guys thinking about the difference and why this is so important. And just mixing it up with the nursing diagnosis in there. All right. I want to flip on that one slide. Does this look pretty ominous? I mean, he's got charcoal around his mouth and nose. Yeah. Pretty presumptive that there's going to be some airway injuries as well. All right. So we talk about clues. There being facial burns, singed nasal hair. I can just smell that. Yeah. Hoarseness, painful swallowing. The mucous membranes or nasal membranes are actually dark or charred. Carbonaceous sputum, like right here. Imagine like, and black stuff comes out. Nice, right? But if you see that, that's a good indication your patient's going to have, respiratory issues from being exposed to fire or smoke. If you know the patient's history, they were in a closed space with a fire out in the shed, lighting the barbecue, or in the basement with the hot water heater or something like that. So fires in enclosed spaces are a lot more likely to cause respiratory injuries. And of course, if there's clothing burns around the head, face, or neck. All right, so if we have injury to the lower airways, we're really getting into trouble, right? And that steam or smoke got way down into the alveoli, down below the trachea and bronchioles. And again, it depends how long they were exposed to it and what kind of other toxic fumes. You've all smelled burning plastic, exhaust, like burning fuel. It's a lot more noxious than just like burning wood or from like a gas line. So the more toxic the chemical, the deeper it got, the more trouble the patient's going to be in. And unfortunately, you might not see it for 12 to 24 hours post the burn. So you think you're okay, right? Check the patient out in the ER, send them up to the burn ward, 7th floor, Methodist Main, right? Yeah, 12 hours later, I'm having a little trouble breathing. I'm a little short of breath. And then that pulmonary edema is developing in there. If nurses aren't vigilant, watching with vitals, listening to patient complaints, doing their assessments, they can have a bad outcome. So you also have to be on the lookout for it, even if you think the patient's okay, because, if they're well enough, they put them on the ward. So you also have to be vigilant when you think of a burn patient. So once that starts to happen, it manifests as ARDS. And what is that?
Acute respiratory distress.
Have you guys had that yet?
No.
I bet you get it tomorrow. So when you're getting your ARDS lecture tomorrow, think about that patient with burns and how it's going to look. All right, so let's move on to chemical burns. Contact with acids, alkalis, and organic compounds. Has anyone ever been exposed to chemicals themselves or know someone who has? Luckily, no. Good. So alkali burns are the worst. And so, I mean, what's an alkali basically? It's not an acid. It must be a base, right? Yeah, very dangerous. It causes protein hydrolysis, liquefaction. We were talking about this the other night in post-conference, right? Like ceviche, when it does the protein. Ooh, right? I'm gonna never eat that again, right? Sorry. And you have to remember, even once you wash it off, it can continue to cause damage to tissue. And some of the common things are like oven cleaner, drain cleaner, very, very strong bases. And then the fertilizers, the anhydrous, nitrogen, that kind of stuff, and really heavy-duty industrial cleaners. Then anybody old enough to remember the West fertilizer explosion a couple years ago? Right? Yeah. So it blew up and was in the whole area. That's the fallout fog and everything. You have to look at for those kind of injuries in patients that may have been exposed to it. So chemical burns. All right. So not only just the skin, what's real important if you get exposed to your eyes, right? Cause some blindness. That was like a pretty vital eye right there. So yeah, you have to think of not just the skin, not just the respiratory. Now we're looking at eyes as well. It gets in the ears, and then if you have enough exposure to a toxin, it can actually have systemic effects in the liver and your kidneys because they're very sensitive to those kind of chemicals. So yeah, not only are we looking at the skin, now we're looking at is there liver and kidney damage? All right, so what do you think we should do? Wash it off, right? Get rid of it. And as far as removing chemically stained clothing, do you think when you get to the hospital you're going to see any of it? I hope not. I hope the ENS used their trauma shears and got rid of it. They're usually pretty good about that. And so, again, with some of these chemicals, especially the alkalis, the tissue injury can continue for like 72 hours or more. So you just have to be on the lookout for it. You thought you were in the clear, but 2 days later, it's like, oh, now we're getting blisters on that site where the chemicals were exposed. And another thing to remember here is call poison control. What are you going to tell them? Hey, I think I got this patient who has a chemical burn. What's a good thing to have if you call poison control? What is it, right? If you're in the hospital, is there something that you can look for? And
Yes, the sheet. The thing.
okay.
Big binder.
Who do I know works in the hospital? Does MSDS?
Yeah.
What's an MSDS? Say it loud. Medical safety data sheets, thank you. And hopefully, wherever the burn occurs, they're going to know what that chemical is and let you know so you can call poison control. And they're going to tell you best how to treat it. So also remember, they're your best friends for chemical burns. And so here we have some nice photos. Oh, I forgot to warn you. This was an anhydrous ammonia burn. And this is the same patient after it healed. And I'm sure that was months and months worth of debridement and treating. But, it looks like this, he's had a good result from the treatment, so that's good. You can recover from it. All right, so now let's look at electrical burns. Coagulation and necrosis caused by heat from the electrical burn. The current passes through the body and can cause life-threatening damage. What would you think of first? Your heart, right? Because it functions by electricity, so if you have an external source of electricity, what could it do? Stop the heart? Change the rhythm to what? AFib? BFib, yeah. I think BFib is more important. What's the really bad one? BTAC, BFib, yeah. Pulseless BTAC, BFib. So it passes through the vital organs. You know, that's worse than just superficially going across or even through like muscle tissue. And Christmas is coming up. People are going to be putting the lights up, right? Yeah, so be vigilant. You might see some electrical burns out there. Makes me think of Christmas Vacation, right? All right, so the severity of the injury is difficult to assess. Why? Because it's inside. What are you likely to see? You can see a small entry wound maybe, right? And a bigger exit wound. And you just don't know what kind of tissue damage was in the path. You know, you grab the electrical wire with your hand, it exits into that puddle by your foot. Yeah, go through your whole body. And you don't know what the damage was. And just a reminder here, low voltage doesn't mean what? Low voltage. It was a radio commercial. So even if you think it's low voltage, be careful. All right, so I thought this was really profound. Electrical injury can cause a muscle spasm strong enough to fracture bones. Like if you've ever seen a patient defibrillated, you kind of rise up, right? All the muscles contract at once. I mean, I can't imagine putting electricity through your arm or your leg where it's enough to cause a contraction strong enough to break your femur. So now what do you have? You have trauma on top of your electrical burns. Now you're treating two things. All right, like we talked about, patients with electrical burns are at risk for dysrhythmias, cardiac arrest. Why would they get metabolic acidosis? Takers? Nobody? Okay, if you have necrosed cells, dead tissue, acids released into the body, in the bloodstream, right? Metabolic acidosis. And where would myoglobin come from? What's myoglobin? Right, it's from the muscle tissue, and then the muscle cells break down, goes into the bloodstream. Where does it go to? And what happens in the kidneys? All gunked up, yeah. So that's one thing you have to look out for with electrical burns. It's pretty common. Also, if you have lysed RBCs, it's going to release hemoglobin, same thing, go to the kidneys. The first thing we're going to get is acute tubular necrosis, right? The tubule is part of the what? What's the basic unit of the kidney? The nephron, right? So you can get acute tubular glomerulonephritis after that. So acute kidney injury. And a lot of our patients already have chronic kidney injury, right? And we have acute on chronic. Yay, more complications. All right, so we showed you the great pictures already, electrical burns. All right, so now we're going to look at how we classify the burn. How deep is the burn? What percent of TBSA? That's a 4-letter acronym. Can somebody help me? There you go. Thank you very much. And where the burn is, you know, because like you said, head and face, or on the mouth, respiratory, some of the extremities, you know, mobility issues, that kind of thing. And, you know, what is your patient starting with? Do they already have heart, lung, kidney disease, diabetes? Are they malnourished? And like I talked about concurrent trauma. You know, maybe you're driving down I-35, someone runs you off the road, so you have head trauma, chest trauma, and then the vehicle starts on fire. Now we're treating two things, right? And the more systems are involved, the higher the mortality. So you have to look at your total patient. You can't just think, oh, it's a burn patient, or oh, it's just a trauma patient. You know, maybe you didn't know they inhaled noxious fumes. You thought they were just a trauma patient. Oh, but they've got respiratory injuries too, inhalation problems. So, you know, always assess your patient. So traditionally, you know, like back when I was a little baby nurse, we looked at, was it a first degree, second degree, or third degree burn? Has anybody heard those terms? So what's a first degree burn? Yeah, it's very superficial, it's red, right? What's the classic thing that makes it a second degree burn? Blisters, right? Oh, look at that. Pretty gnarly looking blisters. And third degree, actual tissue damage, right? It goes through the whole skin and damages the tissues down below. And so the ABA prefers a different method, though, which I'll go through on the next page. Now, also remember that if a patient has more than a 10% body surface area burn, they should go to a burn unit. Where are they going to go in San Antonio? That's right, that's the only one. They tried to do a burn center at Methodist Maine, and kind of stay tuned, right? They're trying to go trauma now. We've got a burn ward, but no burn ICU. So stay tuned. All these changes in medical care. All right, so this is how they want to classify burns now. Superficial partial thickness burns, just the epidermis, the top layer, is pink. You know, it's when you take your hand cookies out, you burn yourself. Usually heals a little. So a deep partial thickness burn, it involves the whole dermis, not just the epidermis, the top. And it's going to look moist, like we talked about blisters, right? There's damage that's causing fluid to escape. Very painful, and it may take up to 2 to 3 weeks to go. Yeah, pretty much equivalent. And then we go into full thickness burn. Involves the whole skin, the nerves, which are in the dermis, right? Muscle, nerve endings, fat, muscle, bone. So it's gone through the whole dermis down into the tissues down below. It can look dry and leathery. It can be white. What's a good email? White and charred. And why would it be insensate? Right, we got rid of those nerve endings. So now, if that doesn't hurt, but what will hurt? Around the edges, where the nerves are still intact. And this deep of burn, you're going to require excision of the dead tissue and skin grafting to cover it back up. Because the skin's not going to spontaneously regrow where it was completely damaged. All right, so here's a nice graphic. The epidermis up here at the top. That's your superficial. And then the dermis here, you have your hair follicles, your sweat glands. That's the deep partial thickness. And then if you have a full thickness, the third, you know, we call third and fourth degree, you see the fat, the muscle tissue, and the bone can actually be damaged. So full thickness. All right, so what does this look like? How would you classify that? Okay, so did I hit somebody say partial? What kind of partial? Superficial or deep partial? Okay, why? Because here it looks like it's pretty much involved, you know, part of the dermis. And what else? It looks moist, right? And I don't see any other tissues exposed. So I would say it's a partial thickness, a deep partial thickness. What about this one? Oh, there's a bad picture coming up. So what do you think about this one? Well, in old school, third degree, right? Full thickness, right? You can sort of see tendons in here. You see, you know, right down here. It goes all the way. It looks like muscle here. So yeah, full thickness. And the charring we talked about. You know, is that going to heal? Probably not. Probably going to have further tissue death. All right. So how do we calculate the extent of the burn? Right. There's a couple of areas. Rule of nines. There's a handy dandy chart called Lund-Browder, and it's more accurate than the rule of nines, but it's going to take longer. The Palmer method. And whose Palmer are you going to use? The patient's, right? We're going to show things at different sized palms, and we get a very different result. So the patient's palm figures is 1%. To me, that might take a little time to estimate. And when you calculate the total burn surface area, you only look at the full thickness and the deep partial thickness, not the superficial. All right, so here's a rule of nines. It's pretty handy dandy. Every body part is associated with a 9. The head is 9%, 4.5 on the front, 4.5 on the back. The trunk, 18% on the front, 18% on the back. So you can kind of just do the dividing line, 9% top, 9% bottom. Each arm is 9%, 4.5 front, 4.5 back. And each leg is 9% on the front, 9% on the back. And what's our last 1%? The perineal area. All right, so that's a rule of nines. Here's the lung Browder chart. Like I said, it's more specific, but to me it would take longer to kind of draw on the little diagram of where the patient's burns were to figure out what the percentage was. And somebody at a burn unit is going to do this, and it'll be in the chart what your patient's burn percentage is and what levels of burn they were. You're going to get that in your what? In your S bar? Always way back to nursing, right? Okay, so that's the lung Browder chart. Palmer method, just remind 1%. And I was right, there's an app for that. I did download one of the apps, and to me, it doesn't seem like it's that friendly to use. I just Googled it and went to the Play Store and downloaded it. It's kind of interesting. So you can flip the patient over, and the only way to tell is like if you're looking at the toes or the heel. And then you can pick which kind of burn you're dealing with, and then just see if I can get it to change. See how it added? Yeah. And then when you go to the next level, it tells you what the total surface area is, and then it actually will tell you on each body part what the total surface area was. So you can download it and play with it and see what you think. I downloaded the NSW one, but I couldn't get it to work. I don't know if I need a password or what. But it's there. You want to play with it? Download it. Got to improve our technology, right? All right. So also the location of the burn is going to have an implication on how severe it is. We talked about face, neck, chest, respiratory problems. What if you had a burn that was all the way around your whole chest? There was scar tissue, there was eschar. Think you might have trouble ventilating a patient? Right. So restrictive problems with chest injuries, hands, feet, joints, eyes. They're going to have trouble taking care of themselves, trouble with mobility, right? So one thing to think about looking forward when you're discharging your patient. And then again, ears, nose, larynx, perineum, higher risk for infections, the one of the complications. All right, you have to remember if there's a burn on the extremity and it goes all the way around, what can happen? Compartment syndrome? It's right up there. And why is that a problem? With circulation, right? So you're assessing your patient, you see that it's burned all the way around, you're feeling for your pulse. Can't feel a pulse. Check it again in 4 hours. No? Probably should notify somebody, right? Because what might they have to do? Surgery, right? What kind of surgery would that be? Fasciotomy, or maybe an escarotomy, depending on if it's scar tissue or eschar or why it's restricted, letting the blood in. A couple of pictures of fasciotomies. This is they just go in, open the compartment with a scalpel, release the pressure so that the blood flow can increase. Sorry, it's a little graphic, but it's what you see. All right, so we talked about the 3 phases of burn management: emergent, resuscitative, acute. We have the wound healing starting, and rehab or restorative. And it's a long haul for these burn patients. Did anyone had a family member or take care of patients in the hospital or a nursing home with burns? Okay. I had one of my college friends, her mom had been burned with candle wax. And I know. And luckily, she didn't have any functional disabilities, but she had scar tissue from the skin grafts on her legs. And, he was kind of like, oh, what's that from? And it's traumatic. You have to retell the story and kind of relive it. So it's something to think about. All right, so the emergent phase. We're getting close to a break here. Immediate life-threatening, right? This phase lasts like up to 72 hours post-injury. And, you know, what's our biggest concern? Hypovolemic shock and edema. Why is there going to be shock? Okay, so when we get third spacing, that's edema. What does the skin do? What's one of its major functions? It's a barrier to the outside, right? You get rid of the barrier, the fluid evaporates. We have hypovolemia. What else happens to the fluid? So we have fluid shifts, right? Patients with 20% or more burns. Hypovolemia is what's going to kill these patients, not the burn tissue itself. So you get a fluid shift out of the blood vessels. There's increased capillary permeability from the burn, so the fluid just goes into the tissues. And you know, sometimes we say things can last up to 72 hours, but this can happen as quick as 20 minutes or even more, depending on the severity and the area of burn. So the fluid shifts out of the vascular space into the interstitial spaces. So what's the implication? The blood going round and round? No. So what are we going to see? Oh. I think I need to move that one down further. This is just an example of edema. So this was his initial photo, and after the fluid resuscitated, they put the fluid back into the vascular system. What did it do? It third space more. All right, so back to fluid shifts. Normally, how much a day do we lose? Breathing out, sweat, in our stools, 400 cc's a day. Severely burned patients, 200 to 400 cc's an hour. Right? What's our total blood volume? Okay, how long is it going to take to get rid of all that? A couple hours, right? So then no more blood going around and around. So what happens? What do we see in our patient? Okay, but how am I going to identify that when I assess my patient?
Blood pressure.
Okay, low blood pressure, tachycardia, right? And there's going to be a lot of edema. Third spacing. So if it's third space, I'll say if the blood's not going forward, it's backing up somewhere. So why wouldn't the blood go forward? Besides the fact that there's not much of it. Is the heart happy? No, right? It's getting decreased blood supply, so you're going to get cardiac failure. Blood's not going to go forward. It's backing up. So it's not going around and around. So not a good picture.
What did you say the volume was?
It's like 6 liters, right? Yeah, depending on how big a tank the person has. Yeah, 4 to 6 liters. All right, and so here we are talking about electrolytes again. I'm having deja vu from DKA. So the sodium goes into the interstitial spaces. So What does that mean for the intravascular blood? Hyponatremia. Okay, so now we have low sodium, but it moved into the interstitial spaces. So what happens now? What does water do? It follows sodium, right? So now we're pushing even more water out into the interstitial spaces, more edema. All right? And so let's talk about potassium again. What am I going to have? Hyperkalemia. Why? From the dead cells, right? The cell membrane breaks, all the potassium goes either into the tissues or into the bloodstream. And so, who cares about potassium? You guys having flashbacks? Didn't you have those 2 weeks ago? Who cares about potassium? The heart, right. Yeah, so now you can start, in addition to the fluid shifts and the decreased circulation of the heart, now you can start having cardiac dysrhythmias. That's going to pump into less blood, right? So we're compounding our problem. So dead cells, hemolyzed RBCs, all that potassium is coming out. You could have hypokalemia. All right, so clinical manifestations. We have shock because the blood's not going round and round in the bloodstream. Full thickness burns. It's not going to be painful except on the edges. So this is what you're going to see when you're assessing your patient. What about the gut? Is it all happy? No. Why isn't it happy? Yeah, is that the first thing that's going to get perfused when there's hypotension? No. So now your gut's not working. Paralytic ileus, if you have the large burns. The patient's shivering. He's losing heat. He's got no skin. So he's terminating heat, right? Because the skin is the number one thermal regulator too, right? Oh, yeah. He's anxious. He's hurting. What about the shivering? What's that going to do?
Increase oxygen demand.
Right, increased metabolic rate. So now we're using all this energy that probably should be used for something else. You have to think about that. Think about energy conservation. So what would be a nursing intervention for your patient that's shivering? Keep them warm, right? All right, and we talked about the hypoxia with respiratory injuries. You may see altered mental status. You may also see that from decreased perfusion, right? So there's less blood going up there, and the blood that's going up there has less oxygen. If your patient is conscious, you have to watch for neuro changes as well. All right, cardiovascularly, we talked about dysrhythmias from electrical burns, hypovolemic shock from pretty much any kind of burn. The extremities can have decreased circulation, lead to tissue extremity, numbness, paresthesia, and then the microcirculation. So the heat can actually just cause what? Blood clots, right? Coagulation. And so you're going to have decreased circulation because of that. You have dehydration, the blood is thicker, sludging, and what else can thick blood cause? Clots, exactly. And where are they going to go?
Your brain.
Everywhere. Where is it important? They go to the lungs, the kidneys, the brain. Yeah. Okay. So we're just compounding our problems. Burn patients are very complex to treat. All right. So the respiratory system we talked about, some of the complications. You have chemical heat burns. Your upper airway, again, it goes to the edema formation, and these patients are almost always intubated because of the swelling. They might have scar tissue. One of the complications is pneumonia. You've gotten rid of the nice cilia layer with the mucus that prevents infection, so you get pneumonia, and then the pulmonary edema we talked about prevents what? Pulmonary edema?
Gas exchange.
Gas exchange. Come on, you guys. Not even Friday afternoon. It's only Thursday. All right, and of course the kidneys are going to be affected. If we don't have good blood flow to the kidney, now I'm going back to somebody else's lecture. Dr. Richardson, what kind of renal failure is that? Pre-renal, there we go. I know, are you having flashbacks yet? Yeah. Good. I mean, you're like, that was last week's test. We flushed that, and now we just want to know about burns. It all goes together. You can't forget what you had last week because we're building on it this week, right? Yeah, this is a continuum. I mean, can you forget everything you learned in the last 8 weeks in Adult 1? I hope not, because we're building on that. That's the whole plan. All right, so anyway, decreased blood flow. You can have renal ischemia. You can have decreased urine output. You know, acute kidney injury, glomerular nephrosis, all that bad stuff. I mean, do you want your kidneys to put out a lot of urine anyway?
No.
Not right now. We're trying to conserve fluids. But, you know, the myoglobin, hemoglobin can all cause kidney injury in addition to just reduced blood flow, reduced function. All right, so like I said, these patients are going to be intubated. They're going to be on the ventilator, which again, after tomorrow, you're going to have more questions about that. And Christina got a good class the other day on the ventilator. But, you know, you'll learn about the respiratory management when you learn more about the airway and respiratory. You know, we have to provide them with enough oxygen. You have to keep the airway open, right? So that you can have gas exchange. All right. We talked about chest restriction. You might have to do an aspirotomy if the chest won't expand because of the scar tissue or the eschar. Frequently, you're going to see a fiber optic bronchoscopy. We just call it a bronch. They look down in there. They can see the extent of the injury. You know, they may breathe. They may take carboniferous fluid tissue out, but they want to see how much of the lung is damaged. So, you know, if you're treating a patient with a burn that's intubated, you know, you might have to be prepared to assist with a bronchoscopy. And if your patient's not intubated, you know, humidified oxygen. You got to increase the amount of oxygen that's in the lungs to increase the gas exchange. It'll probably reduce surface area for it. So that's how you're going to treat your patient. Again, collaborative management. Could you start oxygen on a patient all by yourself without an order? Yes. Absolutely. Absolutely. It's a life-saving measure. And then again, here's another good visual of a patient. It looks like he's had an eschorotomy. Looks like I see a surgical line here across his chest. He is intubated. And you can see another surgical line down here at the side, mid-axillary line. All right, so what's the number one treatment probably for these kind of burn patients? Fluids, right? So it's going to depend on how they are, because are you going to give as much fluid to a 90-year-old lady who weighs 80 pounds as you would to, you know, like a 300-pound linebacker? No. See, then you have to worry about what? Fluid overload, right? So it's going to be tailored to the patient and to their size and to their percent of burn. One formula you're going to see, and you might want to remember it further on past this lecture, is the Parkman formula. It's one of the most widely used ones, and I'll go over on the next slide. You're going to use your urine output to gauge your fluid resuscitation. Once you get enough fluids going, the urine output's going to pick up, and so that's how you're going to gauge your fluid replacement. You want to see 1/2 to 1 milliliter per kilo per hour. So is that more than normal? How much do we normally want to see? And what's kind of the guide if you're emptying your Foley every hour? What do you say? 30 mils per hour. There you go. So if you have a 100 kilo patient at linebacker, so it's going to be anywhere from 50 to 100 milliliters per hour. And that's a good thing because you want to flush out that myoglobin and hemoglobin, right? All right, so here's the Parkman formula. What do you have to remember? Just think about Jeff Davis. Remember the fours, right? So we're going to get 4 milliliters times the percentage of body surface area times the weight in kilograms. And that's going to give us our first 24 hours of fluid replacement. And what are we going to replace with? Good old RL, one thing, easy to remember. We're going to give half in the first 8 hours, the other half over the next 16 hours. So let's do a quick example here. 80 kilogram patient, 20% surface area, 4 milliliters, times the 20%, times the 80%, 6,400 cc's, 6.4 liters in the first 24 hours. That's pretty profound, right? But what you're going to give a DKA patient. All right, and so how am I going to give that? How fast? First 8 hours. Okay, so I'm going to do half of that in the first 8 hours, 3,200 cc's over 8 hours, 400 milliliters. It's right up on the spot. 400 milliliters an hour for the first 8 hours. Okay, and then after that, we're going to give. This is what we plan to give. If the patient's collapsing, you might have to code them and give more boluses. This is our planned fluid replacement. So the next 16 hours, we're going to give that other 3,200, and that's going to be 200 cc's per hour, minimum. Parkland formula. I had to remember it if I was you. Can't? Okay. And since I worked at Brook Army Medical Center, not in the burn unit, this is just another example of fluid replacement, right? So in the first 24 hours, we're going to give some RL, 1.5 cc's per kilo per percent of burn. We're going to give colloids too. What's that? What's the number one colloid? Albumin. Yep, exactly. Why would we give that? It's kind of thick. I hear it. Maybe you need to put a spokesman or pass the microphone on.
They're losing protein, and albumin helps draw water, and so if you give it in the serum, they're going to hold on to water more.
Awesome, thank you. They also do with the amount of particles, right? So we're going to put protein in the vascular system. It's ideally going to pull water from the interstitial space back into the vascular system. We're also going to give some glucose. Why do we need that? Energy, right? And then there's a difference between the first day and the second day. And so just a quick example, 80 kilo patient, 20% burn. We give 2,400 cc's of RL the first 24 hours, 100 cc's an hour, 800 cc's of colloid, and no matter what, we're going to give 2 liters of D5W. So a total of 5,200 in the first 24 hours, within a liter of what the Parkland formula is going to use. But, don't remember the Brook formula. It's just an example of another way to calculate fluid resuscitation. And many hospitals have their own formulas that they use, but Parkland is the most popular, and I try to remember that. All right, we're coming up on 55 minutes, so how about we can come to a break? All right. A good airway, adequate circulation, fluid replacement. They need to look at wound care. These are very complex wounds. They need to be cleaned frequently. They need to be debrided. It all depends on the percent of the wound, the thickness of the burn, what they're going to need as far as cleansing goes. Sometimes you just scrub. You just got to get the non-viable dead tissue and the necrotic tissue off. So we have a good, clean wound bed for the patient to not have an infection and to heal. Right? So, might be just a regular shower if your patient's ambulatory. You might have to do it in the bed with sterile water. Sometimes, I don't know if the wards have cart showers, like for immobilized patients. And they just put on the cart and wheel the whole cart into the shower and kind of hose them down. You see those? That's frequently how they do it in the burn unit. They may frequently need to go to the operating room. I mean, why would you have to go to the operating room? Put the patient to sleep because it's very painful. Yeah. And so that's frequently where they do the bereavement. Like I said, your wound care is going to be tailored specifically to the kind of wounds, the extent of the wounds, but they're typically going to have to go to the shower at least once a day. They wash off all the ointment or creams or whatever they put on, whatever kind of treatment, get down to the wound bed and then reapply either dressings or ointment. So I'll tailor very specifically to the patient's injuries. Sometimes there's new antimicrobial dressings that can be left on multiple days. And so if that's the case, they're not going to go to the shower for the treatment for that particular wound. And so it all depends how they're treating it. Of course, infection is the most serious threat. Can cause further injury. And unfortunately, we have a lot of stuff on our skin, right? Our own flora. It turns against us when we lose the barrier and gets inside and gets in the tissues. So always have to be vigilant of infection. So when you're doing your assessment, what are you going to think about? The methods, are there 5 things that you have to think about for infection? What are they? Someone read aloud.
Inflammation.
What would we call a sepsis alert? What are the 5 things? Temperature. Hypotension. Tachycardia. Tachypnea. What's the last one? It's a lab test.
White blood cell.
WBCs. Thank you very much. I'm trying to get this back to the clinical area rather than just a stare of slide about it. So yeah, infection is probably your number one complication with burns. And so when you're assessing your patient, you have to look for those 5 things. Do I need to call a sepsis alert on my patient? All right. So open method, you don't put a dressing on, you just treat with ointments, antibiotic ointments, very typical. Closed method, there's a million different kinds of dressings to be used on burns now. I mean, every time you go up there, I got pulled up to the burning and I got floated. There's different kind of wounds like, oh, we're using this now. And so, they have to come and say, leave that alone, you can debrief this. Oh, okay. And again, that goes back to what? Competency. Am I competent to take care of a burn patient all myself? Probably not. But they always, whenever you float up there, they always give you the easiest patient. So that's something to look forward to. All right, so closed method, we have a dressing on. And again, depending on the wound and the kind of dressing, 12 to 24 hours, maybe up to 14 days. So they just want to leave it in there, leave the tissue generate. Because if you pull it off, you'd have to start over. So it's all very specific. You're going to have very specific wound care orders on your patient for every one. So these are just some examples. So this wound, it looks like it was partial thickness. You've got some Vaseline gauze, and then it looks like Silvadine cream, silver, sulfidine, Silvadine. And why use silver? It's actually antimicrobial. Surprise, right? Another surprising thing was meta honey. If you didn't know, honey has antimicrobial properties, right? I see some heads going north and south. Yay. So it's surprising. So this has, looks like some sort of gauze dressing on it, the one down here. This one just has burn ointment, silver, sulfidine, Silvadine. Some examples of wound care. All right, so we need to get it covered, right? There's no skin. The skin is gone. We need to cover it. So an allograft, where does that come from? Donors, right? cadaver donors. It's temporary. What's going to happen to it?
They get rejected.
Right, exactly, because it wasn't mine. So it came from a patient that passed away, and their family said, yes, we're going to donate their skin for wound care. But it helps protect, helps keep in the moisture. It's a matrix for skin, for granulation tissue to grow, right? So biosynthetic skin, BioBrain, another brand, silicone membrane with nylon mesh. Covers, protects, keeps the heat in. Like I said, you're going to have specific wound orders with what brand and how long to leave it on when you do your wound care. Other things, kind of more nursing-wise to think about. If you have extremity wounds, you know, what can happen? Contractures, right? Pressure injury, so you want to make sure you do your range of motion, make them extended, elevate them to help the edema, right? And so you can see here the patient is suspended in a sling. It's all wrapped up in gauze. We're going to help prevent the edema. And it's covered, keep it protected. If you have perineal wounds, these patients are very most likely going to have a catheter to keep the urine off of the wound area and to measure accurate INO, right? For men's swan. And obviously range of motion exercises. PTOT are going to be involved if you have extremities, upper, lower, to get the mobility back so that they can have self-care capabilities. Remember, this is still in the emergent phase. All right, what kind of drugs are we going to give these patients?
Pain meds.
Pain meds, right? Because at the end of those wounds, it's very painful. Over the deep tissue injuries, not painful, but the edges are. And are they going to be a little anxious? Probably, yeah. So you're going to give IV midazolam, a lot of Dilaudid, morphine, that kind of stuff to treat pain and treat anxiety. You're going to give PO meds a lot at first?
No.
Probably not, because that gut is kind of slowed down. But once you get circulation restored and bowel function restored, then you want to use that throughout the your med running with IV. You know, we talked about Dilaudid, Ativan, Versed, anxiety. Oh, a tetanus shot. Why do they need that for? Infection, right? You lost your number one barrier to infection. So almost all patients, burn patients, are going to get a tetanus shot. All right, antimicrobial agents. Topically, talked about sodium, sulfamylon, that's kind of older school. But you want to keep the infection, protect it from further contamination to natural flora. All right, we're going to give a lot of systemic antibiotics? No, not unless we have indications of infection or sepsis. So you don't give it prophylactically. Only when a diagnosis of sepsis is made. And, unfortunately, frequently they do a lot, but not preventatively. All right, so again, still in the emergent phase, we're talking about nutrition. Why is it important? Wound healing, right? And you may not know what's the number one infectious fighting organ in the body. It's your gut, right? Because if you put antibiotics in there, you kill all the normal flora, you have a terrible thing. So if you feed the gut, it actually helps your immune system. So you want to start using the gut for feeding as much as you can after the fluid priority. After the fluid resuscitation reestablishes your circulation so that your gut is working and you have motility. So what are you going to assess to check if there's motility? Bowel sounds, right? Because I'll be back to assessment, right? So early aggressive nutritional support, and how do you suppose you do that? If your patient's got a ventilator, how are we? TPN? What's the best way to feed the patient? NG tube, right? OG tube. Or my favorite is the dog hawk. Right, the thin feeding tubes. But dog hawk is one brand of thin feeding tubes. And they're great for clogging up when you put other medications down them, right? Anyway, yeah, feed the gut primarily. TPN, if there's no other way to get nutrition in. What's TPN stand for again? Thank you very much. So TLA, my favorite. Yeah, so early aggressive nutrition for wound healing. And they'll start it as soon as they can. Like I said, decrease the mortality, needed for wound healing, and then again the infection benefit of feeding the gut. All right. So now we're looking at the acute phase. After the 72 hours, we've mobilized that extracellular fluid. So it was all in the tissues. We've given some colloids. We've brought it back in. The sodium has come back in. The fluids all come back in. Now it's all in the vascular system. What do we have to do? Get rid of it with diuresis. Get rid of the edema, right? Good thing to have that folia so we can check our urine output. All right. After the circulation returns, the bowel solids return, and the healing is going to begin on those wounds after the first 72 hours. So you're going to have increased WBCs, and what's that going to look like in your wound?
Granulation.
What kind of drainage? Purulent. Right, that's the word we use. Okay. And then, it can look like eschar, it can look like slop. They do get to look nasty in between debridement. So phagocytosis, the white blood cells go into the wound, take care of the infection, and then they're going to get debrided away. Okay, the necrotic tissue, that's what we remove with the debridement, the slop, or just like the brown, thick, gooey stuff down here. As your wound heals, you're going to see more granulation tissue, which looks like what? Red, beefy, yeah, pink, kind of proliferates. It's going to come in from the edges, sometimes. It's going to come in from the edges, sometimes from the wound bed. If you have full thickness burns, again, you have to remove the eschar, and you're going to require, sometimes you have to do flaps as well. You have to move a muscle to cover bone tissue. And then that, again, is going to have to be covered with a skin graft. Because if you have a full thickness burn, skin will not grow from there. You have to put skin on top. All right, complications in the acute phase. Talk about infection a lot. It's red, there's inflammation. Sometimes even partial thickness burns can become infected. And you just have to assess your wounds. You're going to do it every shift when you come on. You're going to really do a thorough assessment when you're doing your debridement, your showers, your wound care. And again, same with always infection. Temperature, hyper or hypothermia, increased heart rate, respiratory rate, hypotension, and probably might see decreased urine output. If you go to hypotension, pre-renal failure, decreased urine output, you follow that track, right? So we're back to that again. The patient gets an infection. All right, neurosystem. They're not going to have physical symptoms unless it's severe hypoxia from the respiratory injury, or if they have electrical injuries, it can cause nerve damage and they could have numbness. Electrolyte imbalances, again, from stress, from sepsis. Cerebral edema, we talked about that with the electrolyte shifts. You know, cerebral edema. And so when you assess your patient, you have to look for neurologic changes. Some of the medications, if they're getting a lot of pain medicine, a lot of anti-anxiety medicine, they might kind of be neurodepressed. What about like antidepressants? Think they might need some of those? right? So it's a life-threatening, a life-changing incident for the patient and the family. And so, they might need help sleeping at night because of the pain. You don't want to just give them narcotics or things like serotonin. Just you have to do a thorough neural assessment to make sure you're giving them the right combination of medications. So they might be disoriented, they might be combative, they might have hallucinations and ICU delirium. So these are just things to look at when you're assessing your patient's neural status, even in the acute phase. All right, musculoskeletal. We talked about the decreased range of motion, decreased mobility. You want to try and prevent them from having contractions. Obviously, it's a problem that their skin is less supple, less pliant. Even with skin grafts, you have to work them so that they're stretching out. Because otherwise, your patient's going to have contractures that have increased range of motion, decreased stiffness. So GI, we already talked about the ileus. You shouldn't have this as much in the acute phase because you're feeding the gut. You're obviously assessing their bowel movements every day. You're treating them with fiber and or like Miralax, jaw softeners, that kind of thing. Although tube feeding is usually its own remedy for that. Sometimes we call it diarrhea in a can, but there's other ways to combat that as well. Like we said, the enteral feeding, the antibiotics can cause that. And if your patient has diarrhea, what's probably going to happen then? Dehydration, right? Any fluid electrolyte issues? Acidosis, right? Because you're putting all the basic fluid in the pancreas out in diarrhea. Dang, another one, right? Reaching back to another lecture. We're building on that. And then constipation, you give them a lot of opioids for pain, decreased mobility. So you just have to assess bowel function and treat appropriately, whether it's diarrhea or constipation. All right, so we talked a lot about wound care already. We're going to look at it in depth at their daily showers and assess, every 4 hours. Not necessarily the wound itself, but if you've dressed it, you're going to look at the dressing. If you have ointment on it, you're going to look at the increased drainage or if the ointment, kind of sloughed off. But, very thorough assessment of your wounds. The cleaning and debridement according to the orders in your plan. Putting the dressings back on if they come off, like if they're moving around. Some of the newer treatments we're looking at, there's a collagenase. So it's kind of a debridement. Santo is the number one that I've seen used. If you've got the Escar and this love, sometimes those medications help loosen it up when you do your debridement. Helps get rid of the dead tissue. Yeah, Santo. Collagenase. There's other brands out there. This is the one I've seen most used. And they use a lot even like for heel wounds, sacral wounds, that kind of thing, to debride dead tissue. All right, so we talked about excision of dead tissue. You need skin grafting. You take off the eschar. You get down to nice, clean, we're talking about red, beefy tissue. It's a good base for a skin graft to grow on. Clean, viable tissue. What's an autograft?
Using your own skin.
Patient's own skin, right? And so if you put it on a good bed of tissue, it should proliferate and not have rejection issues. So they use what's called a dermatome on an area that's not burned. Hopefully the patient has some that they can donate their own skin from. And then it kind of depends what they put over the skin graft. A lot of times they use like Vaseline gauze, keep the area moist, keep it from drying out and dying. They can attach it with fibrin seal or with staples, and I've got a picture of that coming up. And so we talk about function being restored, reduce the scar tissue with early aggressive excision of the dead tissue. All right, so this is called the dermatome. It sort of looks like a cheese slicer. It takes like a micro thin layer of skin off, and then they put it through this machine here. That it cuts a mesh into it so that it stretches out beyond its original size, and you can cover a larger area of a burn wound. And then this is what it looks like. It looks like a mesh, and you can see how they're stapling it down onto the wound. To me, the donor area almost looks worse than the area that they grafted to. It's kind of very weepy for several days. All right, there's also dermal substitutes they can use. Integra is a bovine tendon matrix. Any ethical issues with that? Maybe, right? What's that? Bovine? Cow. Right? So maybe if you have a Hindu patient, they might not want you to use that. There's also pork skin, temporary covering, so, maybe some of the Jewish religion will have trouble with that. I don't know. These are things you have to think about, right? Ethical issues in burn treatment. Right? So, alloderm is what? Right, it's from a human donor. Is it the patient's own? No, because it's allo. So it's from someone else, and it's probably similar to like a cadaver donor. That tissue, it's going to protect in the meantime, but it's going to be rejected and die eventually. So there's something new called dermograft. And I'm not even sure what the source is, but it has fibroblasts in it. So that's tissue that might generate new tissue. All this kind of stuff. I even heard of one, and I couldn't find it. It's made like from shark, either shark collagen or shark cartilage. Yeah. Crazy stuff. So, you guys maybe if you're working in burn ants, you're going to be on the cutting edge of new treatments. So, let me know what you're using out there. All right, so I actually saw this, the cultured epithelial autograft used at Methodist Maine last semester. They sort of take a postage stamp size piece of viable skin from the patient, take it to the lab, and grow more skin cells in sheets in the lab. So they put a cultured growth medium in there, and we grow more skin cells from the patient's own skin cells. It actually worked really good. It was amazing. They were doing that at Methodist Hospital, right across the street. And ideally, theoretically, you can grow as much skin as you need, but it's not an instant process. It takes some time. Patients with large surface area burns and limited harvesting area are the ones that are going to benefit most for this. Unfortunately, it's fragile, and of course, it's. All right, so this is a picture of the autograft after it's been applied. So you can see these, they kind of look about the size of a 4x4. And so they, when they grow the medium from the culture, from the graft, they have all these kind of little sheets that they put over the skin. And look, that's that guy's whole chest and abdomen. That's a huge area of development. So CEA, cultured epithelial autograft. All right, so just some other collaborative management, pain, continuous background pain, and then the pain from treatments. I mean, it just, to me, the pain just kind of has to be like a low buzz. It's there all the time. And then you have acute pain when you're going to go in and do a treatment. So, maybe you're going to get opioids. Once you start using the gut, patient can swallow the slow release oral opioids. Can you crush those and put them in the dog off tube? Trick question, right? No, you're going to get your whole 12 hours worth of opioid in one dose. Dog's got to be careful of that, right? Nursing implications, pharmacology. All right. And then, analgesics, like I said, angiolytics. They get a lot of stuff to help them become calm. All right, non-pharmacologic, relaxation, breathing techniques, anything you use with your patient to try and help them relax and calm down. Guided imaging, visualization. I've never seen anyone use hypnosis. I've never been hypnotized. Is anyone any experience with it? Yeah, no? Hypnosis? Yeah? What do you use? Oh, wow. Did it help him? Wow, cool. So let's try this this time. Biofeedback, music therapy, anything to help your patient relax and take their mind off their pain. Obviously, PT and OT, to decrease mobility, they're going to be there right from the start. When you're doing your wound debridement, dressing changes is the best time for them to be there and assess their movement and what their plan is for increasing their motion. Active and passive range of motion, and like I said, you're going to have specific orders with how to handle that. You have a CEA graft, you're going to want to do a lot of mobility on it? No, because it's fragile, right? But then they have that immobilized until it takes effect. So just look for your real specific wound care orders. Splints, OT and PT are going to help you out with to support mobility, support movement. You can see this is a real custom splint right there. I know the patient that was getting the grafts, he was basically kind of spreading you on the bed so that if he had his arms close to him, he would get contractures. And so his arms were kind of like spread eagled out across his two overbed tables. All right, again, nutritional therapy, caloric needs. Dietary is going to be involved. They're going to calculate, based on burn percentage, based on fluid needs, different formulas of tube feeds, what the patient's going to get as far as tube feedings, if they're getting tube feedings, or what kind of diet they're going to get. High protein, high carb, just to encourage your patient to eat, get a return from home, and weighing regularly gives you a gauge of your progress, or lack of progress on nutrition. All right. Y'all are following along on your own slides. You're like, he's wrapping it up.